Good evening, everyone, and welcome to the November DSM Solutions Conference call. Tonight's topic, snoring is never benign, part 1. This one's going to be a cliffhanger, a really important topic, something that we always say, snoring is never benign, snoring is never benign. Now we're going to go through why. The second part, and I'll shout this out again at the end, is going to be in January of 2022. No call next month for December. So if you're listening to this after the fact, please join us live for the part 2 call on January 2020. So with no further ado, Dr. Greenman, take it away.
Thank you, Nicole. Happy holidays, everybody. We're coming to you on November 29th. So I hope everybody had a great Thanksgiving last week. And all the best for a healthy, happy time with your families, and wish you a Happy New Year early. So we want to talk about snoring. A lot of our families are going to be together. You're going to have guests coming in. You may be a guest yourself. And so, snoring is an issue, especially when you're sleeping in a different location. And other people, maybe a smaller house. I mean, other people might be able to hear you if you're the snorer, or you may be going into a home where there is snoring. I can remember my grandfather, my father's father, snored so loud that when he would stay with us when my brother and I were young kids, and we could definitely hear him on the opposite side of the house. And it wasn't a tiny house, wasn't huge, but we could nonetheless hear him. We'd have to close our doors. We could, it was hard to sleep. So I certainly can relate to being around a loud snorer. I've had other occasions to be in a small, a small confined area with somebody who snored loudly, and remember not sleeping a wink. So if you have been around a snorer, or you're sleeping next to a snorer, I think you can relate to this, whether you're a dentist whom we're training, or even a non-dentist who might be checking this out on a YouTube or something like that. So, it may occur with or without an arousal of the person who's snoring, as long as the sound is below a certain decibel level. All of the sound comes from the throat, the oral pharyngeal area, and it's due to a narrowing that takes place. But the airway is patent, meaning that there is airflow, and therefore there's no tremendous loss of oxygen saturation in the bloodstream. But there's no real change in the cycling of the breathing efforts going on. Although the noise, like we said, that can arouse a person as long as that noise is up, like say around 40 decibels or so. That is enough to arouse the snorer. Primary snoring, and let's talk about primary snoring. I want to talk about how primary snoring is not benign. Loud chronic snoring is a cause of many comorbid conditions, i.e. other disease factors, not to mention what it does to the bed partner. So it's the sound of the throat constricting. Think of the throat getting narrower. And as the throat narrows, it causes vibrations in the soft tissues. The soft tissue of the soft palate, that vibration is what makes that loud snoring sound. But those vibrations also affect the other tissues in the throat. So how often is snoring? Well, 30% of the adult male population over 30 snores with regularity. Okay, men more than women, 2 to 1. But after menopause, women begin to catch up. The prevalence of snoring, increases, and studies show, well into the 6th decade, and then often will decrease in older individuals. And then we're speculating here, but the theory is that might be due to decreasing amounts of deep sleep, non-REM and REM sleep, that occurs as we age. And I think all of us who are experiencing, their 6th and 7th decades can attest to the fact that we don't sleep like we used to. So that may be part of why this snoring phenomena seems to decrease as we do get older. Adults, well, there's two trajectories for snoring. There's the adult trajectory, which, again, it parallels, where there's obesity present. There can also be diabetes, hyperlipidemia, which is a fancy name for high cholesterol, and high blood pressure. But snoring itself is the warning sign in adults. But children aren't immune to snoring either. And chronic snoring will peak in children between 2 and 6 years of age. They also will have associated sleep apnea with that, but even the snoring in and of itself will disrupt their sleep patterns enough where we'll see excessive daytime sleepiness in children. So really, the message here is that chronic snoring in children is not benign, and we want to make sure that we stress that. If there's, of course, an upper respiratory tract infection, cold or the flu or something like that, that's impairing airway, the nasal breathing, yeah, snoring may be occurring. But if you have a child that's snoring continually, that is a problem. Apnea indices in children are much more sensitive than for adults. You may recall that in an adult, this apnea-hypopnea index, i.e. the number of times a person doesn't breathe at all or breathes inadequately, if it's over 5 in an adult, that is considered significant, and that would be a diagnosis of mild obstructive sleep apnea. However, you can see by this graphic here that in children, an AHI of greater than 1 is considered significant and leads to a diagnosis of sleep apnea. And in children, we find that there's a neurocognitive impairment, and i.e. they don't do well in school. That's what delayed execution skills are. In fact, some researchers have determined that there can be an up to 10-point reduction in IQ scores in children that have chronic snoring and obstructive sleep apnea. So back to this picture here, and I want everybody to look at it. If you see if your child has this posture, i.e. lips apart and obviously mouth breathing, and doing it every single night, this is an indication of sleep apnea. And I want that to be real clear, that oral posture, this oral facial development, is what we look for in children. And I can tell you that if there is proper oral posture with nasal breathing, no obstructions, we'll get into more of this in part 2, then these children will have normal facial development. They'll have plenty of room for their teeth and typically won't need the orthodontist. But 22% of kids will have occasional snoring, when we talked about that, but up to 12% will report habitual snoring, and those are the kids that we have to be real concerned about. So here's a little case report that we have. It's a 6-year-old boy, and he goes to the ENT physician, the ear, nose, and throat surgeon, and the complaint is nightly snoring and restlessness at night. Doesn't sleep well at night, gets up a lot during the night. Physical examination reveals that this child is overweight and has grade 3+ tonsils. Now, how tonsils are graded is if they're absent, they've been removed, that's a 0. If it's a 1, that means that they're hidden, that you can look down the throat and you don't really see any tonsils. That would be a 1. A 2 means that they're sticking out and obviously apparent on visual examination. A 3 is that they're so big that they're almost touching, and a 4 would be that they're touching. And that means that their tonsils are touching together, and they're also touching the uvula, that little thing that hangs down in the back. And so that indicates grade 4, where there is just really no way to get air in unless the child tilts the head forward and breathes through the mouth. So this kid had almost a grade 4 tonsils. Now, if we subject a child like this to a sleep study, which is called a polysomnogram, PSG, what percentage of children do you think will have obstructive sleep apnea as defined by and a positive test result being an apnea index of 1 or the greater than 1 or an AHI of greater than 2. Okay, so this is like kind of a test question. Well, 50% of the kids will have an AHI, an index between 1 and 2, meaning that they are testing positive for obstructive sleep apnea. And that's huge, and that's something that we need to consider. And again, it also talks back to the fact that chronic snoring in children is never benign. So it should be assessed in all children. Okay, there should be a follow-up evaluation, history and examination. If you're a dentist and you see children in your practice, you need to observe them, observe how they're breathing. Are their lips together and with a relaxed jaw posture and breathing nasally, or do they have their lips apart all the time? Okay, ask the parent about sleeping, sleep quality, snoring, etc. That should always be asked. And if you're finding that there's snoring and other signs and symptoms, then a referral is indicated. Now, are they going to get a sleep study? Or if there are enlarged tonsils and adenoids that go with that, well, would that be the first line of treatment? And I believe strongly in considering that and doing everything we can to clear the airway, because that should be our first line of defense for these kids. If they have enlarged tonsils and adenoids, remove them. Now, studies show that they're going to these tissues will reduce and actually get back to normal by mid-teenage years, but by then the damage is done. And I always liken this to the analogy is that if you came home one day from work and you see a little smoke coming out the back corner of your house, well, that fire will go out, whether you call, you don't have to call the fire department, the fire will go out, but you'll lose your house. So best to call the fire department and get intervention for these kids right away. So that's what we're talking about. This is a slippery slope to consider that there's anything benign about snoring. So Colin Sullivan, who's the inventor of the CPAP. I was lucky enough to hear him speak at an American Academy of Dental Sleep Medicine meeting. Nicole, maybe you ought to note this slide and fix it up a little bit. That snoring, causes irreversible nerve, muscle, and vascular damage, in the oral pharynx, the bellow and oral pharyngeal areas. What is the bellow pharynx? That's the part of the throat that's behind the soft palate. The oral pharynx would be the area behind the tongue. And so together, those areas are of soft tissue are areas where we're going to see this irreversible nerve, muscle, and vascular damage. So what this is telling us is that heavy snoring significantly increases the risk of carotid atherosclerosis, meaning hardening of the carotid arteries and the and plaque formation along the lining of these arteries. Okay, it also will stimulate platelet aggregation, and platelets, as you know, are responsible for creating blood clots. And so this platelet aggregation and formation of these microclots then can dislodge, and where are they going to go from the carotid artery? They're going right to the brain. So this is something to be considered. Increase, and this increase is independent of any other risk factor, including measures of sleep apnea as well. So there are studies, in well-regarded refereed journals that are showing that heavy snoring in and of itself is not benign. Now, what about the person who has to sleep next to this sufferer, to snore with sleep apnea, or just snoring in and of itself? These people, these bed partners, will report increase in aches and pains and daytime fatigue and sleepiness. Okay, well, we all know the consequences of inadequate sleep when it comes to reaction time. 4 hours or less of sleep your reaction time in a driving simulator is no better than somebody who's got a blood alcohol level of over 0.8, which would be considered drunk driving in any of any of our states. So secondhand sleep deprivation is significant, but there's also increases in what we call fibromyalgia, which is now called widespread pain, depression, memory impairment, sexual dysfunction, even weight gain. So people who have to put up with snorers are putting themselves at risk. And maybe that's a good thing that many people that have to sleep next to a snorer actually are going to go sleep in another bed, because they do recognize the effects of poor quality sleep and secondhand sleep. So let's get back to this inflammation that we talked about with snoring. And what I want to show in this picture is the location of the internal carotid artery. Okay, the internal carotid artery is there's two of them. Okay, and they're located just below the surface of the posterior wall of the oral and bellow pharynx. So if you look back and you see the back of the throat, just under that tissue on either side of the midline lie the internal carotid arteries. And so that is where, and then from there, obviously, they're going in to provide blood supply to the brain. Okay. This platelet aggregation and dislodgement of these microclots, if you will, then can lodge themselves in the tiny blood vessels within the brain tissue and then starve off brain cells, neurons, and therefore can, over time, lead to strokes and lead to mental impairment, dementia, and things of that sort. So here's a good picture from a textbook that I recommend to all of our dental sleep apnea clients. And this photograph is showing the oral, the oral pharynx, okay, after a surgery called UPPP, where it's part of the soft palate, the uvula, the tonsils are removed. Okay, and I like this picture because you can really see where these internal carotid arteries are. And I'm going to get a little laser, or let's get a pen. Okay, and so one of them is here, and the other one is here. Okay, and so that loud chronic snoring and vibration will cause irreversible nerve, muscle, and soft tissue damage, and that's what we're talking about with loud chronic snoring. There are other surgeries that are done as well, but again, surgery typically is a last resort for most sufferers with obstructive sleep apnea and chronic snoring. As just an aside story, and I tell this to all of our clients, early on in my career, when I started treating obstructive sleep apnea, I had a patient, a man, come in that had this surgery. Well, the surgery is not without risk as well, because what happened is during the surgery, the surgeon nicked the posterior wall of the oral pharynx and severed. Actually, no, he didn't sever it, but he damaged the carotid artery, and there was a big bleeding event. They were able to staunch the bleeding, save the patient's life, but he ended up having a stroke right there on the operating table. So again, just want to point that out. And here's some other pictures, and so you can now understand that just below the surface here is are the internal carotid arteries, and you can see the degree of redness, inflammation, and swelling that takes place in the soft palate and the uvula in chronic snorers. So with that, I want to thank you for listening to me for part one. In part two, we're going to get into a little more information about why are we snoring? I mean, is it just because we're obese, or are there other factors as well that are contributing to this problem? And so with that, I want to turn it back over to Nicole and thank everybody for listening.
Fantastic. Thank you so much. So everyone listening, part two in January of 2022, have a great night. Have a great holiday. And we are really looking forward to chatting with you and seeing what 2020 can bring.
Thank you. Good night.
Night.